mechanism of action, it gets converted into the bacteria with the help of catalase peroxidase, which is coded by CAT-G gene. ठीक है, CAT-G की अगर रेजिस्टेंस हो जाएगी, that causes high level of isoniazid resistance. So high level of isoniazid resistance में you cannot use isoniazid in high dose. In low level of isoniazid resistance, which can occur with INHA or Cas-A, which helps in coding the enzyme which helps in mycolic acid synthesis. तो isoniazid का mechanism क्या है? It inhibits the mycolic acid synthesis. So what is the mechanism of action of isoniazid is? It inhibits the mycolic acid synthesis. It is bactericidal in nature, and there can be high level of resistance or low level of resistance can occur with this mutation in the genes CAT-G, INHA or Cas-A gene. It works best on the fast multiplying bacteria. ये rapidly multiplying जो होते हैं, they act best on them. They act both on the extracellular or intracellular bacilli. They are the first line agent, can also be used alone for prophylaxis of the TB. So isoniazid is considered is a highly efficacious drug and also can be used for prophylaxis, metabolized by acetylation. So there could be fast acetylators and slow acetylators. This is important. अगर fast acetylator होता है, ठीक है, 30 to 40% population is fast acetylator and slow acetylator में 60 to 70% population आती है इंडिया की. जो fast acetylator होते हैं उनमें hepatotoxicity is seen. ठीक है, if you are using isoniazid, hepatotoxicity can be seen, and slow acetylator can cause pyridoxine deficiency, may lead to peripheral neuropathy or peripheral neuritis. Okay, so what are the main side effects with it is hepatotoxicity, peripheral neuropathy, psychosis due to CNS stimulation, and sideroblastic anemia, which when you take the peripheral smear, it just looks like iron deficiency anemia, but there is increase in the iron content in the cell in sideroblastic anemia. Now, a lot of drug interactions are also there with isoniazid because it is an enzyme inhibitor of cytochrome enzyme. So, phenytoin, or if you are giving diazepam or warfarin, you have to be careful with this. But usually these antitubercular drugs are given in combination. So, rifampicin is an enzyme inducer, so they balances each other activity. You give with isoniazid pyridoxine. पैरिडॉक्सिन देंगे, प्रोफाइलेक्सिस हम देते हैं 10 मिलीग्राम, और अगर हमें थेराप्यूटिकली देखनी है पैरिडॉक्सिन तो वी विल गिव 100 मिलीग्राम. ठीक है, पैरिडॉक्सिन की डेफिशिएंसी हो जाती है व्हेन यू गिविंग द आइसोनियाजिड बिकॉज इट इनहिबिट्स द यूटिलाइजेशन एंड इंक्रीजेस द एक्सक्रीशन ऑफ द पैरिडॉक्सिन. Then we come to rifampicin, which is a rifamycin, semi-synthetic derivative of rifamycin. Now this, the mechanism is, it inhibits the DNA-dependent RNA polymerase enzyme. Okay, so it inhibits the transcription of the proteins. Protein synthesis ultimately will be inhibited because of the transcription is inhibited. It will not for mRNA to this protein synthesis will be inhibited, and it acts best on the intermittently dividing bacteria that are known as spurters. ठीक है, वो isoniazid किस पे बेस्ट एक्ट कर रहे हैं? रैपिडली डिवाइडिंग पे. दे एक्ट बेस्ट ऑन द स्पर्टर्स. स्पर्टर्स क्या होते हैं? विच आर इंटरमिटेंटली डिवाइडिंग. 3 स्टेजेस में ये बेसिलाई होते हैं. आइदर दे आर रैपिडली डिवाइडिंग विच अकर्स इन द कैविटी ऑफ द लीजन. They are in the caseous material. These intermittently dividing bacilli are found. They are known as spurters, in which rifampicin acts best. Intracellular, slowly multiplying organism, in which pyrozinamide acts best. They are also bactericidal in nature. They have a good sterilizing action because they are inhibiting these spurters. And resistance can develop because of the mutation of RPOB gene. It is not only effective for Mycobacteria tuberculosis but also very effective for atypical Mycobacteria. It is also effective for lepra, Mycobacteria lepra, and also for gram-positive and gram-negative bacteria. Okay? So rifampicin has a broad spectrum of action. So it is used in atypical mycobacterial infection, leprosy, prophylaxis of meningococcal or H. influenza meningitis, and carrier state of these disease, and second and third choice in multi-drug resistance or methicillin resistance, Staph aureus infection, diphtheroids and Legionella infection, and as a first line therapy with brucellosis with doxycycline, it is given as a first line choice. So these are all the uses and the clinical applications of the rifampicin. Now it is always given empty stomach. Whenever rifampicin is given, what is important in pharmacokinetics is it is given empty stomach because the food inhibits its absorption. There is a hepatic clearance, so you can give in renal failure cases, rifampicin can be safe. It is an enzyme inducer, you have to be careful with the drug interaction, which is not there much with the rifabutin. It turns the body color, body fluids to orange in color. Okay, so urine and all the orange tinge will be seen when the rifampicin is given. And the toxicity, again, they are hepatotoxic. They can cause cutaneous syndrome like rashes, abdominal cramps, flu-like syndrome. With intermittent dosing, it is more. This flu-like syndrome or cutaneous syndrome. Okay, this was important in rifampicin. Then we go to pyrazinamide. Now pyrazinamide, it converts into its active form pyrazinoic acid. Now this works best in the acidic condition. So wherever the inflammation is more or inside the cell where the acidic pH is more, it works best. That's why it's very good drug for intracellular bacilli. जो सेल के अंदर bacilli होते हैं उस पे ये works best, and it also inhibits the mycolic acid synthesis and disrupt the cell membrane. ठीक है, mycolic acid synthesis को भी inhibit करती है, and by some mechanism, by inhibiting some fatty acid synthase enzyme, different mechanism compared to isoniazid, and also disrupt the cell membrane. It is a bactericidal drug, but it's a weak bactericidal compared to isoniazid or rifampicin. They are the most efficacious drug as an anti-tubercular agent, isoniazid and rifampicin. It is also known as a very good sterilizing agent, and it is very useful for meningeal TB also, and also the penetration is very good for isoniazid. Okay, CSF penetration is very good for isoniazid also. Now toxicity पे अगर हम आते हैं इसकी, again it is also hepatotoxic. It can also cause hyperuricemia. You have to be careful in the gout patient, and abdominal discomfort and loss of diabetic control are the other side effects associated with pyrazinamide. Now coming to ethambutol. Ethambutol, it inhibits the mycobacterial arabinosyl transferase enzyme, which is synthesizing the arabinogalactin, which is again synthesizing the cell wall of this mycobacteria. Now this is a bacteriostatic drug. This is the only bacteriostatic first line drug. All other are bactericidal. This is bacteriostatic in nature. This acts best on the fast multiplying bacilli, ethambutol. And clinical application is, it is also used for atypical mycobacterial infection with this. Toxicity is, you can remember the retrobulbar neuritis or uveitis is the main toxicity with ethambutol. So when you're giving to children, you have to be careful because children cannot notify there is disturbance in the vision, because whenever there is disturbance in the vision is noted, it has to be stopped. So what is the main toxicity with ethambutol? Again, retrobulbar neuritis, peripheral neuritis and hyperuricemia. Hyperuricemia और किसमें हो रहा था? Pyrazinamide. ठीक है, pyrazinamide की जैसे इसमें भी hyperuricemia होता है, but it is safe drug in pregnancy. Which drug is contraindicated in pregnancy? Streptomycin. streptomycin is contraindicated in pregnancy. Resistance can occur with the mutation of EMB-ABG, which code for this arabinosyl transferase enzyme. Now coming to streptomycin, which was used first in this, but now the resistant pattern is quite common with this streptomycin. Now as an aminoglycoside, it inhibits the protein synthesis by binding to 30S ribosome. Bactericidal in nature, and it works best on the extracellular bacilli. Now it is considered as a supplemental first line drug, and what is the main toxicity with this is nephrotoxicity, ototoxicity, just like the other aminoglycosides. They are coming in injectable drugs. So we just see or summarize all the mechanism of action of all the drugs. So what are the mechanisms? Now there are three recently introduced drugs are bedaquiline, delamanid and pretomanid. Okay, for the drug-resistant tuberculosis, these are the three recently introduced drugs. Now it works by inhibiting the ATP synthase on the cell membrane. That is bedaquiline. Okay, as you can see on the top, by inhibiting the ATP synthase enzyme, it disrupts the cell membrane, causing the leakage of the cell membrane. So that is bedaquiline mechanism. Inhibiting the protein synthesis, all these aminoglycosides, they inhibit the protein synthesis. Inhibiting the mycolic acid synthesis, that is isoniazid, ethionamide and delamanid. They all inhibit the mycolic acid synthesis. So that's why if there is resistance to isoniazid, you see the cross resistance with this, ethionamide. Or you can see with delamanid also. But usually with isoniazid, one resistance to isoniazid, there is seen cross resistance with ethionamide. Then inhibiting the folate metabolism, para-aminosalicylic, this pass is inhibiting the folate metabolism and the DNA synthesis. Inhibiting the cell membrane, pyrozinamide, with the mycolic acid synthesis also. Inhibiting the transcription, rifampicin, by inhibiting DNA-dependent RNA polymerase enzyme. It inhibits the transcription. Inhibiting the cell wall synthesis, ethambutol, cycloserine. Okay, ethambutol and cycloserine, it inhibits the cell wall synthesis, affecting the DNA synthesis, fluoroquinolones, clofazimine. They damages the DNA, fluoroquinolone and clofazimine. So just few questions. Best for rapidly growing bacteria among the first line agents. Maximum and minimum CSF penetration. Maximum is isoniazid and minimum is streptomycin. Maximum sterilizing action, pyrozinamide. Best for intracellular bacteria. Best for bacteria in caseous necrosis, rifampicin. Spurters are there in the caseous area. Only for extracellular bacteria, streptomycin. Safest in renal failure. Safest in renal failure, rifampicin. Least toxic, rifampicin. Associated with peripheral neuropathy, psychosis, transient memory loss, isoniazid. Orange discoloration of urine, retrobulbar neuritis, ethambutol. Notcidal, ethambutol. Contraindicated in pregnancy, streptomycin. So coming to the second line drugs, when the second line drugs are used, when the patient is resistant to the first line drug, because they are more toxic and compliance is very poor with the second line drugs, and the duration of therapy is also prolonged because they are less efficacious compared to the first line drug. Now coming to the important points of the second line drugs, will not go much in it. Avoided in HIV patient, thioacetazone. Remember, for the MCQ point of view, they are avoided in HIV patient, thioacetazone. Hypothyroidism is seen with ethionamide. Cross resistance to isoniazid, ethionamide. Neuropsychiatric adverse effects, cycloserine. Again, neuropsychiatric adverse effects were also there. Psychosis was also seen with isoniazid. Causing pseudojaundice, uveitis or polyarthralgia, rifabutin. ठीक है, rifabutin also causes this. Uveitis can also be there with ethambutol. Now, National Tuberculosis Elimination Program 2020. So there is according to 2012 data and 2019 data, there is 2.64 million people per year. This is the incidence of the disease get infected with this tuberculosis every year. And under National Control Program, it is to provide free treatment to all. ठीक है, अगर आपने एक बार डायग्नोज कर दिया, फ्री ट्रीटमेंट दी जाएगी पेशेंट को. एंड 1997 में there is this National Tuberculosis Control Program was launched, and it provides also the treatment guidelines, which was latest revised in 2010. Now, it is considered as a notifiable disease since 2012. Now, how can be notified? There is again a web-based reporting system was also launched, that is known as NICSHE. You have to notify all the cases of TB, and this is the web-based reporting system that is known as NICSHE. Enabling the management, compliance, and contact tracing. These are the three main important arms of this program. That is, you have to give the management, you have to manage the case, compliance has to be ensured, and contact tracing has to be done. Then there are three new drugs which has been introduced: bedaquiline, delamanid, and pritomanid. For these MDR TB, multi-drug resistant and extremely drug resistant TB. Then pharmacovigilance program of India is also linked with this tuberculosis, National Tuberculosis Elimination Program 2020, to manage the adverse effects, because these drugs are highly toxic because they are given for a long time. Aim is to achieve this cure rate of more than 85% in new sputum positive cases, and to eliminate this by 2025. That is the target for this program. Okay, that much is important here. But for more about the program, you can read in any community medicine book. Now, coming to the drug sensitive, they are classified into drug sensitive, drug resistant TB, and other issues and other types. Now, drug sensitive TB, you are classifying the patient into new and previously treated patients. Both are considered as, पहले दो कैटेगरी होती थी, कैटेगरी 1 न्यू केसेस, कैटेगरी 2 प्रीवियसली ट्रीटेड फॉर मोर देन 1 मंथ, उसको प्रीवियसली ट्रीटेड केसेस कहा जाता था. अब दोनों को एक ही रिजीम हो गई है, दोनों में एक ही रिजीम दी जाएगी. दैट इज इंटेंसिव फेज और कंटिन्यूएशन फेज होता है. इंटेंसिव फेज किसको टारगेट करता है? रैपिडली मल्टीप्लाइंग बेसिलाई को टारगेट करा जाता है उसके अंदर, एंड द एक्शन इज फास्ट, and the main aim is to convert the sputum negative, ठीक है, जिससे कि infection spread now as fast as possible. So there is 4 drugs for 2 months, HRZE, 4 drugs for 2 months in the intensive phase, and continuation phase the aim is to eradicate the disease, and that is for 4 months, 3 drugs, HRE. Now there is daily regime is given, and this is fixed dose combination are given. So with this National Tuberculosis Elimination Program 2020 guidelines, now they are given as continuous treatment, daily regime. पहले intermittent regime थी, daily regime दी जाएगी. 4 drugs 2 months and 3 drugs 4 months in the continuation phase. Drug sensitive TB, when it is asked, you have to write this regime. So total regime is for 6 months. Now these are the doses which you need to remember. 300 milligram, that is 10, 15, 30, you can remember 10, 15, 25. In adults, you can remember 5, 10, 25, 15 and 15. For children, daily dose, it is different, but you need to remember the adult dose 5, 10, 25, 15 and 50 milligram per kg per day. So 5, 10, 25, 15, 15, you can remember that is the milligram per kg per day. So 300 milligram rifampicin, 600 milligram isoniazid, pyrozinamide 2000 milligram, ethambutol 1500 milligram, and streptomycin 1000 milligram. So at least these doses you can remember. They are given based on the weight of the patient. Number of tablets are given because they are available as fixed dose combination. Okay, so according to this, these number of tablets are given based on the weight category. But if the dose is asked, you need to know the doses. Now coming to the drug resistant TB. So with the treatment regime, you must be clear. Combination therapy is given. What is the benefit of combination therapy? कौन बताएगा? Why it is must to give here combination therapy? Prevent the resistance. It's very important because अगर single drug it will cause resistance very fast. You need to prevent the resistance. You have to give the combination therapy. It will decrease the duration of therapy. It will decrease the infection rate. It will decrease the adverse effect. Now there is mono drug resistance TB. Mono drug resistance TB, that is MRTB. So mono drug resistant TB intensive phase is for 3 to 6 months. That is based on the sputum negativity rate. You will examine at 2 months, 3 months, 4 months, and then you will extend it accordingly. So intensive phase, you have 6 drugs and 4 drugs are there in the continuation phase for 6 months, and that is for 3 to 6 months intensive phase. Now what all the drugs you have? R for, Z for, E for. So the 3 drugs for which the bacteria is sensitive in the first line. So you are including the 3 drugs from the first line for which the bacteria is sensitive. And then comes your injectable and fluoroquinolone, levofloxacin and kanamycin. Clear? 6 and 4 drugs, again 3 and levofloxacin. Injectable drugs are usually not given for more than 2 months. ठीक है, अगर इन केस इंटेंसिव फेज आपका इंक्रीज हो रहा है तो उस केस में अगर 2 महीने से ज़्यादा आप इंजेक्टेबल ड्रग दे रहे हो तो देन यू हैव टू गिव intermittently, that is thrice a week, not daily injection. What is the toxicity with these injectable drugs? Nephrotoxicity and ototoxicity. Polydrug resistant TB, again in that case you have to choose any 2 drugs. Polydrug is more than 1 drug, resistant to more than 1 first line drug. Okay, so you can give rifampicin, Z or E जिससे sensitive है, plus levofloxacin, kanamycin and 1 second line drug, that is ethionamide. And again you can this injectable drugs you can remove, and that is for 6 months. The same continuation phase and intensive phase. ठीक है, polydrug resistant and monodrug resistant TB. ठीक है, सेम ड्यूरेशन के लिए देनी है, 3 to 6 months for intensive phase and 6 months for continuation phase. Then rifampicin resistant TB. Now rifampicin resistant TB, the treatment may go for 24 to 27 months, just like the MDR TB. Now, but there is shorter regime is also there for rifampicin resistant TB now, which is given for 9 to 11 months. So for 6 to 9 months, these drugs can be given, 2 of the second line drug and rest the same, and 18 months you can give these 4 drugs with this one first line, one fluoroquinolone, and other two second line the drug, that is cycloserine, ethionamide and cycloserine. What is there in the shorter regime? They have added isoniazid. They have seen that isoniazid can be added. And moxifloxacin for levofloxacin and clofazimine for cycloserine, if it is replaced, then it can shorter the regime to 9 to 11 months. So this is in the drug resistant TB. They have again classified the drugs as group A, how you need to include them in a regime. Okay, so group A comes fluoroquinolones, group B second line injectable agent. In this order you will include it in the regime. Other second line agents, and they are the add-on drugs in which pyrazinamide, ethambutol and high dose of isoniazid, D2 bedaquiline and delamanid, and D3 the other drugs will come. ठीक है, ये जो classification है, it is for drug resistant TB. Grouping is being done. Based on that, they are included in the regime. So for MDR TB, you have 24 to 27 month total duration. And how many drugs? 6 and 4 drugs. MDR TB, that is resistant to rifampicin and isoniazid. MDR TB होता क्या है? Resistance to rifampicin and isoniazid is known as multi-drug resistant TB, or any other drug, but resistance to rifampicin and isoniazid is multi-drug resistant TB. And when it is also resistant to injectable or fluoroquinolone, then it is extensive drug resistant TB. So what is the regime here? You can give the rest, one of the first line drug, in intensive phase, one of the first line drug, 4 you have given the second line drug, 1 injectable or fluoroquinolone can be added. Okay, this is given for 6 to 9 months, and 18 months these 4 drugs will be given. Second line, you are giving the 4 second line drugs. Multi-drug resistant, 4 second line drug will be given in the continuation phase. With new drug, there is another regime. There is 7-5 drugs are given. For 6 to 9 months, you can add bedaquiline with the 4 drugs of second line: ethionamide, cycloserine, linezolid, clofazimine, and capreomycin, that is either capreomycin or kanamycin, or moxifloxacin or levofloxacin can be added. Okay, 1 injectable you have added, you can add either moxifloxacin or levofloxacin with bedaquiline. So 7 drugs are there total in the new regime with the new drug. 6 and 4, 7 and 5. And that is again for 24 to 27 months. So MDR TB duration is 24 to 27 months. Then come to extremely drug resistant TB. You have rifampicin and INH or fluoroquinolone or one or more of the second line injectable drug that is resistant to that is known as XDR TB. Now again it is increased now to 24 to 30 months. So total duration for XDR TB is 24 to 30 months, and you are giving 8 drugs here and 5 drugs. For 6 to 12 months, these 8 drugs, and 18 months, these 5 drugs is to be given. So you will exclude those drugs for which it is resistant. Exclude these first line for which it is resistant. Fluoroquinolone is excluded, and in injectable capreomycin can be given. Moxifloxacin, ethionamide, cycloserine, then you can give, because it is seen that moxifloxacin, they are not resistant to this moxifloxacin. Those who are resistant to, even it can work even in those which are resistant to fluoroquinolones, other fluoroquinolones. So moxifloxacin will be added, capreomycin will be added, ethionamide, cycloserine, pyrazinamide, linezolid, clofazimine and ethambutol. So So these are the 8 drug combinations. So you have to do the drug sensitivity test, and accordingly you can add the drugs. So 8 and 5 drugs are added, and this regime is for 24 to 30 months. Again, with the new drug also, you have this regime. Bedaquiline is added. For first 2 weeks, bedaquiline is given 400 milligram, and then after that it is given as 200 milligram twice a weekly, and it is not extended for more than 6 months. When you're giving the bedaquiline, it is not given more than 6 months generally. And the main side effect with this newer drug is QT prolongation. You have to take care. Now coming to chemoprophylaxis of TB. So where you need to give the prophylaxis, if the Mentox test is done to see the presence of the antigen. If the Mentox test is positive, or who are the contacts of the patient, immunocompromised HIV patient with positive Mentox test, or HIV infected patient which are exposed to multi-drug resistant, or patient with history of TB but disease is not actively present. So first drug you will choose is isoniazid, 300 milligram once a day with, you can choose, if it is not working, rifampicin is the second alternative for prophylaxis. And rest you can see, I will not go much in this. Now atypical tuberculosis and other issues. In HIV and AIDS, it is very common this TB, because immunocompromised patient more likely to have these infections. But you can include rifabutin in case of rifampicin. The regime will remain same. Pregnancy, streptomycin is contraindicated, and you can avoid pyrozinamide. That was considered earlier, but now it is seen that all these drugs, HRZE, are in the category C in the pregnancy. They are classified as category A, B, C. So C is not much studies has been done in these patients. Okay, so you can use the same regime. What is the main regime for drug sensitive TB? 4 drugs, 2 months, 3 drugs, 4 months. Okay? Or you can give 2 HRE, 7 HR. But streptomycin is contraindicated. Pyridoxine has to be given 10 to 25 milligram per day. Breastfeeding women, again the same course you have to give, and give the BCG vaccination and INH prophylaxis. For 6 months, INH preventive treatment is to be given as a prophylaxis. Mycobacterium avium complex infection is also prevalent, especially in these immunocompromised patients. Quiet. So what are the 3 drugs? What you can see? What are the 3 main drugs? For Mycobacterium avium complex, what are the 3 main drugs? Clarithromycin or azithromycin. You can give 500 milligram BD or OD. Azithromycin once a day, clarithromycin 500 milligram twice a day. Ethambutol as 15 milligram milligram per kg daily you can give, with rifabutin 300 milligram once a day. So these are the 3 main drugs. You can, with or without fluoroquinolone, you can add. So this is the regime which is given for 2 to 6 months. And then there is this is the intensive phase regime, and 2 drugs are given in the maintenance phase. So what are the drug in the maintenance phase? You have clarithromycin or azithromycin, these, or ethambutol or rifabutin में से एक, या with or 1 fluoroquinolone as mentioned above can be given. So 2 drugs here, 3 drugs in the intensive phase. So that is the duration of therapy for this, and continuation phase is for 18 months. Then prophylaxis, you can choose any of the drug, azithromycin, clarithromycin or rifabutin. What are the 3 main drugs in this intensive phase? And rifabutin. And 2 drugs in the maintenance phase? clarithromycin and ethambutol. So these regimes are important. This can be asked. Whenever you're giving these drugs, you have to manage the adverse drug reactions. So give the proper instructions: nausea, vomiting, drowsiness, flu syndrome, arthralgia, peripheral neuritis, hypersensitivity reaction. If it is, stop all the drugs and start one by one and see to which it is there are hypersensitivity reaction. With ethambutol, you can see optic neuritis, hepatotoxicity. You have to be very careful. So which drugs can be given in hepatotoxicity? You can continue with streptomycin, ethambutol, one of the fluoroquinolone, and you can start one by one the drugs. And then the therapy will also get extended for 18 to 24 months. Now what is the role of corticosteroid? Corticosteroid के कहाँ use है in the management of TB is not used ordinarily, but it is used when patient is seriously ill, or if there is hypersensitivity reaction occur, or if there is a meningeal, renal or pericardial TB or pleural effusion is there, or in case of AIDS patient, or it is remember contraindicated in intestinal TB, and it is when started, it has to be gradually withdrawn when the general condition is improving. So there are these questions which will be given to you already, which we'll discuss later on. Now there is drug therapy. We can't do anything. You have such a limited time duration. We have to cover up drug therapy of leprosy. So what are the two types of leprosy is there? Paucibacillary leprosy and multibacillary leprosy. क्या difference होता है? Less than 5 lesions, single lesion will be seen. It is not as infectious as the multibacillary leprosy. Quiet. So paucibacillary leprosy, more than one nerve are infected, and not more than one nerve are infected in the paucibacillary leprosy. So they are not infectious. इनमें कौन सी आती है? Tuberculoid leprosy और borderline tuberculoid leprosy. इसके अंदर आती है lepromatous leprosy and borderline lepromatous or borderline leprosy. This is the classification of the drugs used for leprosy. Sulfone, which is the oldest drug, that is Dapsone. 3 main drugs में आती है Dapsone, clofazimine and rifampicin. ठीक है, Dapsone, clofazimine and rifampicin, and others which are effective are fluoroquinolones, minocycline and clarithromycin. Dapsone में आते हैं. Dapsone is a leprostatic drug. It is just like it is a sulfonamide, so inhibits the mechanism. क्या होता है sulfonamides का? Folic acid synthesis inhibitor. So it also inhibits that and inhibits the purine synthesis and DNA synthesis. Metabolized by acetylation and undergo intrahepatic circulation just like rifampicin. Another important drug interaction which is asked with rifampicin is oral contraceptive failure with rifampicin. Why? Enzyme inducer. Side effects, main side effects with Dapsone is GI irritation, fever, rash, methemoglobinemia, hemolytic anemia is the important side effect with Dapsone, and sulfone syndrome. क्या होता है sulfone syndrome? As you can see in the picture, it is a hypersensitivity reaction to Dapsone. Acidapsone is the repository form which can be given for 3 months. ठीक है, एक repository form है, once in 3 months can be given acidapsone. It is an alternative drug for pneumocystis jirovecii infection which is in AIDS patient. और कौन सी drug दी जाती है to prevent this infection? Cotrimoxazole. So that again Dapsone can also be given as an alternative drug. Drug of choice for dermatitis herpetiformis, which is also an autoimmune disorder. So this is the mechanism for Dapsone and this is for rifampicin. Clofazimine. Clofazimine is again a leprostatic drug and it is an anti-inflammatory activity also. So It can be given in lepra reaction. When you give these anti-leprotic drugs, it may cause lepra reaction. Now, mechanism is it interferes with the template function of the DNA. क्या mechanism होता है clofazimine का? It interferes with the template function of the DNA, damages the DNA. Side effects is GI irritation, ichthyosis of skin, discoloration of the skin and secretion, as you can see in the picture. So these are the side effects, and due to anti-inflammatory action, it is used for lepra reaction. So clofazimine is also used in lepra reaction. There are two types of lepra reaction. Then you have rifampicin, which is bactericidal and most effective drug. It prevents the development of resistance. So again a combination therapy is given, and again you have these other drugs, ethionamide, though effective but not given because of hepatotoxicity. Ofloxacin, pfloxacin, sparfloxacin, minocycline or clarithromycin are the other drugs. The National Leprosy Eradication Program. It was started in 1955 and it is converted to this control program is converted to this eradication program in 1982. Now the incidences has greatly reduced from 0.57% to 0.007% at present. National Health Policies 2017 now aim under this program to achieve the elimination status by 2018. That was the aim of this National Eradication Program. Now coming to the regime, you have rifampicin 600 milligram once a month. In case of multibacillary leprosy, you are giving these three drugs. Rifampicin 600 milligram once a month, clofazimine again 300 milligram once a month and 50 milligram daily, and dapsone 100 milligram daily. कौन सी दो ड्रग डेली दी जाती हैं? Dapsone and clofazimine 150 milligram and monthly, and clofazimine. Possibacillary, you have two drugs, rifampicin and dapsone 100 milligram daily and 600 milligram once a month rifampicin. That is for 6 months, that is given for 12 months. ठीक है? So this is the regime for. Then you have the other, and in case of resistant to these drugs, resistant cases, the therapy will extend to 2 years, in which you will be using the other drugs, that is the second line drugs. First line कौन सी है इसमें? Dapsone, clofazimine and rifampicin. Second line में कौन सी आ गई? Fluoroquinolone, minocycline, clarithromycin. So these drugs will be used. Now they are used for 2 years. Okay, इतना याद रख लेना. Lepra reaction is there, lepra 2 reaction is there. We'll just see when you start the therapy, what happens. Type 1 is delayed hypersensitivity reaction, also known as reversal reaction. And type 2 is Arthur's type of reaction, that is antigen antibody reaction. जब bacilli निकलते हैं, when you're giving the drug, so these lepra reactions can occur. What occurs? Type 1 किस में दिखता है? In multibacillary or possibacillary type of cases, but specifically in the possibacillary it is seen more, that is borderline tuberculoid, borderline or borderline lepromatous. ठीक है? So in less severe cases, type 1 reaction is seen more common, and it is multibacillary severe cases of the leprosy, lepromatous leprosy. You will see type 2, that is erythema nodosum leprosum. क्या दिखता है इसके अंदर? Skin lesions suddenly become reddish, swollen, warm, painful, tender. New lesions start appearing in case of type 1, and type 2 you will see the tender subcutaneous nodules. They will be recurrent and subside within few days, and they are better felt than seen. So these are the typical symptoms of type 1 and type 2. Nerves are enlarged, tender and painful. Neuritis will be seen. Nerves may be affected, but it is not common in type 2 reaction. अगर nerves दिख रही हैं affected, it is mainly a type 1 reaction. ठीक है, ये दोनों difference हैं. Then other organs are not affected here, while other organs are infected in type 2 type of reaction. So दोनों को differentiate करना होगा. Then you can differentiate accordingly. General symptoms are not common. Here you will have this fever, joint pain, red eyes, watering. All this will be present in type 2 reaction. Now what is the treatment? You will give clofazimine, corticosteroids. ठीक है, treatment क्या है? Clofazimine, corticosteroid. In type 2 you can also add on give anti-inflammatory agent like aspirin. You can give chloroquine, you can give thalidomide, etc. ठीक है.